Hi, this is Pediatric Nursing Module 1 associated with the way things are divided up in your Canvas course. And so we're looking at a bit of an introduction of what is pediatric nursing, some basic facts about child development, and some basic things in terms of concerns for pediatric nurses. This is not meant to be the entire scope of what my LVN students are supposed to learn. You have assignments in Canvas and quizzes and reading assignments, so understand that I'm looking for you all to have an overview of pediatric nursing for LVNs based on all the assignments that you've been given, not just this one PowerPoint presentation. However, it should help you quite a bit, and as you know, you'll be taking a ATI test to evaluate how well prepared you are to take the NCLEX exam after we finish this advanced nursing course for LVNs. So what we want to do is just look at an overview of pediatric nursing. They have different specialties in pediatric nursing, and also pediatric nursing is a specialty for the LVN nurse. Many of them do wind up working in doctor's offices, clinics, and some are being hired today also in acute care. Just depends on what hospital you go to apply for a job. Pediatric nursing involves the nursing care of children from birth to 18 years old. It also involves a lot of interaction with families, parents and siblings. Sometimes we may have a broad understanding of what a family is too, of which you'll read about in your textbook. Pediatric nursing takes place in really a variety of settings: acute care, doctor's office, clinics, community, home health, and really actually schools. School nurses are very involved with pediatric nursing. We'll look a bit about growth and development. You all already took a class before you were admitted to the LVN program about development across the lifespan. So we'll touch on it today. Understand that this is something that you should know very well. Certainly when you take the NCLEX, they're going to ask you some questions on the NCLEX to make sure that you understand different assessments that you would find for children at different ages. Obviously, the newborn is quite a different stage than your 18-year-old. Health promotion is really important, and vaccines that we give to children are included in that. So pay attention to that, and then of course also caring for children who are acutely ill is a part of pediatric nursing. What are some of the current things that pediatric nurses are having to deal with and that we would be concerned about in our country? One actually is childhood obesity. This is much more of a problem than it was in the past. And as you know, when we were studying diabetes earlier in the school year, we have quite a problem today with diabetes type 2. And this used to only be present in adults, and more often showing up in middle age or later years. So the fact that we now have children who are obese and being diagnosed with diabetes type 2 is really a problem, as we've discussed before. They're getting a much earlier start with problems with blood sugar control and all of the complications that go along with diabetes we could expect in the future. So doing what we can in terms of health promotion to help children, help their parents, to prevent problems with childhood obesity is extremely, extremely important for the pediatric nurse. Homelessness also can be a problem. Homelessness is a problem, of course, a health problem for our adults, but there are many children that are also homeless, and their access to medical care may be more limited. The fact that they are moving around from place to place more often. Be sure and read your textbook about some of the difficulties that go along with being a homeless child. A lack of insurance is another problem, and some parents don't have insurance, health insurance for their children. You want to be aware of ways for a child to be insured other than just the employment of the parent. If the parent doesn't have employment that offers insurance, often this can really be a difficulty for children. So understanding a bit even about how to access Medi-Cal could be important for some of your children. We also have children that are really living in unsafe neighborhoods, and this affects things like diet and activity level. These children are often kept inside for longer periods of time. They have more sedentary activities. And then also, of course, just the threat of violence in an unsafe neighborhood. And all of us living near LA really understand that we have some children that have been severely injured or killed just in something like a drive-by shooting that they have nothing to do with, except they're children in the wrong place, wrong time. Lack of exercise, as I mentioned, contributes to childhood obesity. Lower vaccination rates in this country also have caused some problems for some children, such as problems with pertussis, and we have had some infants across the United States who have caught pertussis from people in their family, people that they were exposed to in the community, and actually died. So understanding a bit about vaccinations, which is on our last module, but we will talk at length about vaccinations, community-acquired infections, and children. Community violence, already we have alleged to a bit. We have to understand it's not necessarily always just being in an unsafe neighborhood. Homes that have problems with violence, domestic violence, these children can be, very much at risk. So you want to pay attention to the fact that nurses are mandated reporters, and pediatric nurses do come across situations where they may have some suspicions, and that's all we need. We don't have to make a judgment about people or what is happening in someone's home, but if we have a suspicion that a child may be subject to violence, definitely you want to remember nurses are mandated reporters, so we must report it. Community violence also, of course. All right, so any kind of problems within the community, and children may be there, this certainly is a stressor for our pediatric population. What are some of the different settings? I already mentioned it, but it's worth repeating. Different settings for pediatric nurses can be in a clinic. There are hospice settings for children. We do have children who are terminally ill that nurses are interacting with. Certainly schools, as I've mentioned, hospitals for acute care, and then home health. And in my own experience, I did cardiac home health at a time, as many of you know, and we were sometimes sent out as cardiac home health nurses to visit children in their homes, assess them, help with medications, sometimes IV medications. I was an RN, still am an RN, but definitely I was sent out to some children's homes who who were extremely ill with heart disease, and they were at home and needed the help of a nurse. I mentioned that we have a fairly broad definition of family, and family can be biological, legal, or also just emotional. So a family is who they say they are, and I think one of the ways that nursing has progressed is that we really have stopped being quite so legalistic about who is the family of a child. So we understand that a family might be a nuclear family with two biological parents, brothers and sisters, siblings, but there are also some alternative types of families, and some families are let's say they're foster care families, all right, or they are a grandmother caring for a child that is the primary caregiver, and we have many families where grandparents actually are the primary caregiver for one reason or another to their grandchildren. Preventing medication errors is an extremely important issue for pediatric nurses. And one of the things you absolutely want to understand is the smaller the child, the higher the risk of a dosage error causing really severe impairment or death. And it is one of the things that hospitals especially are looking at and finding ways to create policies and standards of care that will help prevent that. So this is just some of the things that you would need to realize are happening in the field of pediatrics with nurses who are giving medications. 2 nurses check all medication that's being administered to an infant. So that means 2 licensed nurses. You're not going to check it with the CNA that's working with you. You can check it with another LVN. You can check it with an RN that you may be working with, but there must be, if you have a child 12 months or under and you're giving medication, then you must check that you're giving the right medication that's ordered, and also that the dose is really correct. We cannot afford to be lax about this, students, all right? So when you as some of you will be, and I know some of you are really interested in pediatric nursing, and I sure enjoyed it when I was a charge nurse on a pediatric unit. I loved the kids, but you've got to really remember this is a very, very responsible position that you have, just being a pediatric nurse and giving medication, and you do not want to be in error in terms of what you're giving or how much you are giving of something, okay? No interactions with nurses preparing medication in the medication room. How many of us, even over the last year, the amount of time that we have spent together at med cards giving medication, and how many of you have been interrupted along with me while we're preparing medication, while we're calculating a dose, while we're looking for a medication. We all know there are some look-alike, sound-alike medications. Certainly for a pediatric client, if you're giving something IM, the difference of a very small amount, 0.01, 0.02, when you're drawing up a solution can really make a difference in terms of what you're really giving that patient. Having the thought process interrupted for a nurse that is standing there preparing medication is difficult. It doesn't matter what the age of the patient, and we want to be especially careful, because we know we don't have much room for medication dose errors when we're giving them to such small little people. So not only do you want to ask someone not to interrupt you and bring a problem or question to you after you've given the medication, you also want to be careful that that's not the nurse that you're choosing to go up to and ask a question to, whether you're a student or whether it's one of your coworkers, okay? We use computerized medication records pretty much everywhere now. This does tend to prevent medication errors. There's one less person involved in the transcription of a medication order to the MAR. Just that in itself really helps. Also, things are often color-coded, if you've noticed, on your computerized MAR, and that helps us too realize, oh, you know, maybe we didn't catch it. It's green. It looks like we should have given that medication, you know, an hour ago, or that medication is due now, and we're more aware of it if it's on a computerized MAR. Also, especially our larger hospitals have really gone to having their own pediatric unit-based pharmacist. So there may be a pharmacy on your floor that actually has their own pharmacist that is just dealing with dispensing medication and processing orders for those pediatric patients. So they will be real expert also on recognizing any kind of dosage error. All right, and we all know once in a while a physician may make a mistake. That doesn't mean we go ahead and follow through with it. That means we're really trying to catch it, and what is a normal expected dose for a child of that particular age and weight is really, really important. The Joint Commission safety imperatives, this applies to adults, but it also is, again, extremely important. We're not going to forget this when we are pediatric nurses and caring for children. So we read back all verbal orders. We don't just take verbal orders from a physician anymore. We will read back to him what he has told us. So this is whether they're on the phone or they've happened to just catch you in the hall and said, you know, give such and such to such and such a child. Repeat it back to that physician. It will save a lot of patients that we know there hasn't been any misunderstanding about what the physician has actually ordered. Hands-off report gets to be extremely expensive. I don't mean that. Important. Hands-off report, you want to be sure and use your SBAR, your situation, background, action, right? Okay, go through your SBAR, make sure that when you're giving a hands-off report, you are reporting all the pertinent information that next nurse needs to know in order to take care of that patient. Now, this includes, of course, not just from shift to shift, but if a pediatric patient goes from one unit or to another, or goes to the surgical suite, or is coming back from the surgical suite. Okay, anytime one nurse is handing over the responsibility for a patient to another nurse, that hands-off report should be very thorough, and using the SBAR should help you a lot. There's a list of do not use abbreviations that the Joint Commission has given us. Most of you, as brand new nursing students, I exposed you to that a little bit in pharmacology. That all still really holds true. Also remember that we always put a 0 before we put a decimal point. So if you're writing about a dosage and it's 0.5, you're not going to just put 0.5, you're going to use 0.5. I'm not going to spend time telling you about what not to do sometime in terms of abbreviations. Sometimes with brand new students who've never previously used abbreviations in the first place, it can be really confusing. But you do have those lists in your pharmacology book, and some in your pediatric textbook that you're using this term. Critical test result reporting is extremely important. And so when a lab calls and gives you a abnormal lab report, you need to understand that if it's critical, if it makes a difference, and we talk to you all the time about what would be critical when you're looking at lab work and what kinds of things would cause a doctor to change their order. Those things must be reported and documented that you've reported them immediately. Okay, we don't wait hours for something that is a critical result. So for instance, if a child's hemoglobin level has dropped significantly and is significantly below normal, you know the physician is going to need to do something, perhaps order blood. So it needs to be reported right away. It's not something that you rest on. We'll look a little bit about developmental things that you can expect. This is not in any way thorough. You've all had your development across the lifespan class. You have your textbooks to look at. So I'm just pointing out some of the main things that I would want you to know. For an infant is considered a newborn at the time of birth, clear up to 1 year of age. So a lot of changes that happen in that time period. And I am just sure I can promise you that your NCLEX exam will ask you about some of the milestones of what you can expect at different times for an infant in terms of development. If the development is lagging, that's something that is significant that pediatricians need to know. And there may be some type of intellectual, physical developmental delay for that child, and the sooner we can identify and provide assistance and help for a child who's experiencing some developmental delays, the better outcomes we have for those children. So here we go. Important milestones in terms of gross motor. Central incisors, so I'm talking about their teeth in case that confuses you. So usually the central incisors usually come in around 5 to 7 months. So those are the front teeth. Usually the first teeth that the child is getting. They should be able to hold their head up when lying down at the age of about 3 months. Now we know some children can do this sooner. That's never a problem, right? But if you have a child much over 3 months and the parents are reporting and you assess that the child can't hold their head up when they're laying down, then this is something to be sure that the pediatrician is aware of. Infants should be able to roll over, but from about 5 and 6 months of age. And those of you that are on Facebook, that type of thing, you may have some friends, you may have some parents that you've seen. They'll even put up videos of some of these milestones that their infants are accomplishing, especially if it's a first child, right? Okay, they should be sitting up by about 7 months. Okay, pull themselves up to a stand by about 9 months. Now we know we have some very fast walking infants, and they actually are starting to walk at 9 months, but they should be able to pull themselves up to a stand. So normally, and most of us have seen infants do that, they'll hold onto the couch, they'll hold onto the coffee table, and they will pull themselves up and they'll stand there. Some a little more shakily than others, but they get stronger. Cruising, that's talking about a child that is walking around, still holding onto the furniture. Okay, so this infant not only stands up, now by about 10 months, you'd expect that they can start taking steps, but they're not letting go and walking on their own yet necessarily. They're holding onto that coffee table, that chair, that couch, whatever they can grab onto. So we call that cruising. So cruising around 10 months, and by about 12 months, when they're a year old, they do begin to stand alone. At that time, also, they're walking. I think your textbook says 9 to 12 months for walking. not holding on to anything. I didn't put that in here because you could have a child clear up to 14, 15 months when they really begin to let go and start walking in, and generally we're not concerned about that. Growth charts are always included in your pediatric client's chart, okay? And when you are at a clinical site, it wouldn't matter if it was a clinic, doctor's office, even a new admit to a hospital, nurses are frequently measuring the child's height, their weight, calculating the body mass index. Now sometimes we have charts that will do that for us, and we just use the chart. And also the head circumference. When I have taken pediatric nursing students out to Kaiser Sunset out in Los Angeles, all my students have had lots and lots of experience measuring height, weight, head circumference, okay? An infant weighs generally about 3 times their birth weight by the time they reach 12 months, and about 2 times their birth weight by the time they reach 12 months. So just to give you kind of an idea of the rapid growth between being a newborn and being a 12-month-old child. Okay. Breastfeeding is really the favorable way for a mother to provide nutrition. However, we don't want mothers who have difficulty with this or can't. We're not trying to guilt them into it. But it is important for the nurse to know what are some of the benefits of breastfeeding, and there's been quite a bit of research to show that there is a lot of benefit. One is it does reduce the risk of reflux, and many infants can have GI problems of really gastric reflux. So this is what we're talking about. And mother's milk, of course, kind of makes sense. It's more easily digested by the infant than, say, cow's milk. It does provide protection from infection. A lot of the immunity that the mother has to infections that are out in the community are passed on in mother's breast milk to the infant. Infants that are breastfed have less asthma, they have less eczema. Just as two things to let you know, you'll see even more when you are reading in your textbook. And there are long-term benefits to breastfeeding that really says that children have improved cognition and motor function when they have been breastfed. So there's a lot of reason to be encouraging to your mothers, again, not judgmental. And pediatric nurses, of course, interact a lot with mothers and mothers of infants. So these are some of the things you can tell your mother. Also, out in the community, to support breastfeeding mothers, there is an organization called La Leche, and you can find it on the internet these days. And also, they have put out pamphlets, and there is even a book that the La Leche League has published for mothers of infants. Sudden infant death syndrome is still a problem in that infants, we're talking about an infant that is seemingly healthy and then is found dead, usually in their crib. Usually, it's a sleeping infant, and then the infant is found dead. There's no real discernible cause, so we don't know yet why this happens to these little babies. And of course, it's it's very tragic for the family. They may have had the child, say typically, 5-6 months. The child may be in age, and the child is very much part of the family. There's a large emotional attachment, and so then to find these babies dead is really, really difficult. We would call it SIDS, or sudden infant death syndrome. 2 to 6 months is the time of highest risk. What we can do is look at what are the risks, what kinds of things increase the risk of SIDS. One is during the period of time between about 2 and 6 months. The other thing is a young teenage mother, their infants seem to have an increased risk for SIDS too. So your 14, 15, 16-year-old teenage mother needs to be understood as having a child that may be at increased risk, and you certainly can offer some suggestions to that mother in terms of how she positions the infant. For instance, we actually have known since the 1970s research that if an infant is placed prone on their tummy, they have an increased chance of SIDS death. So we really try and teach moms of infants today to place the infant on their back in a more supine position. Now, interestingly, I know I've talked with you all before, the difference between when something's implemented sometimes and when the research. So there was research in the 1970s. It really wasn't starting to be implemented on a wide-scale basis in terms of the positioning of infants until the 1990s. So just FYI, and how important it is for nurses to pay attention to research. Males seem to be at increased risk, and again, no one knows why. Some other kinds of things that increase the risk is a baby put in a crib that has a lot of pillows, that has blankets. We really try and ask that they don't have an abundance of blankets, and really place the baby on their back, and don't put a pillow in the crib. Failure to thrive is another problem that you may find a child diagnosed with. And this is when the measured weight and height is significantly below the norm. They don't necessarily know why the child is failure to thrive, but a certain number of these young children do wind up dying. Others later do fine, but it is a diagnosis that will get a young child admitted to acute care. FTT is failure to thrive, and these are some of the things that the pediatric nurse should be looking at. If you notice way down at the bottom there, it says maternal depression, and so simply having a mother with postpartum depression can really affect the welfare of the child sometimes, and so that can contribute to failure to thrive. Not saying it's the mother's fault. What it actually really means for us is that we need to encourage families to be supportive of mothers who are dealing with depression, and they need some support emotionally. They also need some support in terms of childcare. Children with recurrent infections, children who have problems with nutrition may have a failure to thrive situation, any kind of feeding problems. We talked a little bit already just previously about the child who may have, let's say, problems with gastric reflux. Children who aren't meeting their developmental milestones can be a failure to thrive people also. And of course, the parents' knowledge base about infant care is something every pediatric nurse wants to be assessing. And often that's something that we can help patients out with. And as we know, research has shown that nurses tend to have more time and spend more time with any patient, and certainly parents of small children. So really important for us to always assess what is the knowledge base of that parent. Car seat safety is really important. Hospitals will not, by law, will not send an infant home without having checked to make sure that the car seat that the newborn infant is going to be placed in will be safe for that child. Car seats should be in the back seat, preferably in the center. They should face the back, and they have to be certified for the appropriate age and weight of that child, and what kind of car seat the family has for their child will change according to the child's weight. Toddlers are young children between the age of 1 year to 3 years. The toddler stage is a very mobile stage, right? I mean, now this child is up and walking, and well, I think they're just cute as could be. You will find parents, though, that find them very, very challenging, and they do have their own challenges because this little one is beginning to be more autonomous and more mobile, and has discovered the word no. Toddler safety, because of those kinds of reasons, is really a primary concern of the pediatric nurse, and we want to be able to be teaching parents how to keep their homes safe. We're going to need to spend great efforts when they're admitted to a hospital that we've kept them safe. Always, if you have a toddler under your care, you are thinking safety. Even if you're in a clinic, right? You are going to be sure there's a parent, or you are going to be with that child. We don't leave them alone. These are some of the things that we can teach parents about safety in the home for toddlers. Baby gates, and where would they go? At the top and bottom of stairs, right? Bathrooms. There are toddlers who have drowned in the toilet simply by toddling on into the bathroom and leaning over a toilet with an open top, and the child slips in. So lots of hazards in bathrooms and kitchens for our toddlers. They do need constant supervision. We do not leave them alone. We ask parents to put child-proof locks on any cabinets. Toddlers are very active. They're discovering. They're constantly exploring the world around them in their environment, and so we certainly don't want them to be getting into anything within a cabinet that might be hurting them, such as poisons. Okay, anticipate that toddler could climb, and I made a little note down here for you, but toddlers can drag a chair from one place to another. So you need to be aware of that. They are smart enough to see, oh, I want to get up on top of that cabinet, I want to be on top of that dresser, and they will drag a chair over for them to climb up on to get there. What kinds of things do we expect to be happening for the toddler? Toilet training definitely is the time. Often by about 3 years old, most children are toilet trained. We try and not put horrendous, horrible pressure emotionally on the child. You do need to understand that in terms of toilet training, physiologically, children do need to be ready. That myelin sheath needs to have formed over those nerves that can control continence. your toddler generally loves to play, but they're more often involved in parallel play, not necessarily play with another child, but they are very happy to play alongside, next to another child, and we'll call that parallel play. They have a very rapid language development. 300 to 500 words is the norm by the time a child reaches 3 years old. They also can be very negative. Remember, I said they've discovered the word no, and they will use that word frequently, and they tend to have what we might call egocentrism. They're pretty much looking at the world from their point of view. You can't really expect them to see someone else's point of view at all. The preschooler is a child between about 3 and 5 years of age, and as the label implies, this child is pre-formal school education, although many people do enroll their children in a preschool by the time they reach 3 years old. So between 3 years old and when the child starts kindergarten, they may very well be enrolled in a preschooler, or they may be home. Education is not compulsory in this country at that particular point in time. What do we expect from the preschooler? The language and vocabulary has increased tremendously by age 5, so up to about 1,500 words by age 5. They can speak in 4 to 5 word sentences. They usually are taught their numbers. They can know their numbers between 0 and 10. Preschoolers actually really love to count. They love to learn their colors. They can identify colors. They can begin to really also identify letters. And you will generally see a preference for the right or left hand during the preschool age. Many years ago, before my time, left-handedness was looked at as something sinister and not good for a child, and very sad to say there were young children really pressured to use their right hand when they really had a left-handed preference. We know today that that's just ridiculous. Whatever right or left-hand preference the child has, that's normal. That's the way their brain is developing. Let them use their dominant hand, whichever one that is. We can teach parents a little bit about discipline, and these are some important things that I've listed here for you. One is we want to teach the parents to be fair, be firm, be consistent. Inconsistency causes a lot of chaos in the life of a child, and actually the life of the home, because a child does not necessarily understand what really is expected. If something's expected one time but not expected the next time, this causes a lot of confusion for children and makes it harder for them to really respond to directions that they're given by parents. Timeout, and most of us have heard of this by now, but it's when a child has misbehaved, deliberately disobeyed a parent, and we put that child in a place that's quiet, without a lot of stimulation, and to give, in many ways, to give that child a consequence, and then to give that child time to kind of pull themselves back together, okay? 1 minute for every year of the child's age. So a 3-year-old, we're only talking about 3 minutes, all right? We're not talking about any long, extended confining a child to one place. Often what happens is the parent will simply be advised, give this child a quiet place, let them sit down, and give them 1 minute for every year of the child's age. Okay. Fear is a very common experience. The hospital bed and room is something that we try and make a safe zone, which means often if a child has to have some kind of uncomfortable treatment, an injection perhaps even, that child is removed from their safe zone and taken to a treatment room. We want the children to feel as safe and comfortable in their rooms as possible. All right, and fear, of course, is a very common childhood experience. Client teaching can be done with play, and we even have child life specialists in larger hospitals, teaching hospitals, that can afford to hire child life specialists, and that child life specialist often sometimes even has a playroom that the child can go to play. They supervise the children, they provide age-appropriate play. For that child. Always looked like a fun job to me, to have a job like that. And they do often sometimes some patient teaching. So if a child is going to go to surgery, they will use toys and things that the child may be familiar with. Let the child play, and in that time, and terms that the child's familiar with, and in that time, teach the child about what they may expect when they go to surgery or when they're going to have an IV. For instance, an IV could be explained to a young child as that it's like a straw and it's going to deliver fluid into their body like a straw. Medical care should be planned around playtime so that we're not interrupting children during their time in the playroom and suddenly going in and providing some kind of medical care. Okay, I think we show much more understanding to children now than had previously been done, let's say in the 60s and 70s, even 50s, 60s, into the 70s. The school-age child is considered a child that's between the ages of 6 and 12. And these children, as we know, are in the school system or they're being homeschooled, but their education is compulsory, and hence the term school-age child. Erickson, that you all have studied before in your psychology classes, Erickson describes the school-age child as having the goal of mastering industry. They are achieving things that can be academic, social, cognitive, and they're very concerned with this. If we think about the things we know school-age children learn to do, they learn to ride a bike, they learn to read, they learn to write, they learn to participate in social activities with other children. They can join baseball teams, soccer teams, Girl Scouts, Boy Scouts, whatever it may be. There's a lot of achievement that happens in the ages between 6 and 12. Adolescence is the last stage of development, and it goes from age 13 up to age 18. Many of you will have noticed I gave you an assignment to write a paper and describe the differences between a 13-year-old adolescent and an 18-year-old adolescent. Cognition is definitely one of them. The 18-year-old is much more able to deal with abstract concepts, be able to plan for the future than, say, the 13-year-old. What to expect in adolescence? Of course, a very rapid physical growth happens for our boys and our girls. Puberty sets in, sexual feelings set in that the child needs to learn how to cope with and express appropriately. These are all new things. They have a different body, right? Once puberty sets in, they have increasing analytical capacity. So, I don't think your book says this, but it is pretty well researched. Males tend to lag just a little bit behind the females in this. We were talking about increasing analytical ability. Definitely there's a difference between a 14-year-old and a 16-year-old, for instance. So we want to bear that in mind. Often we may have a teen that is the same size we are, but that doesn't necessarily mean that their ability to think abstractly, to analyze something, it's not really necessarily at the point of an adult yet. Peer approval, as we all know, is extremely valuable to the adolescent. It's highly, highly valued. Many experts will tell you that it's valued by the adolescent more than, say, parental advice. Something that sometimes is quite frustrating to our parents. But definitely a time of very rapid growth and major changes between 13 and 18 years old. So I look forward to seeing all your papers about what you have found out. Causes of injury and mortality for teenagers are really not, mortality is not so much because of disease. We all know that there are children and teens, adolescents who do wind up with terminal diseases. However, we have more deaths that are really caused by risk-taking behavior, more injuries that are caused by risk-taking behaviors that kind of go along sometimes with adolescents. So I've given you just a brief overview here of what some risk-taking behaviors might be for an adolescent. Texting while driving has caused many accidents. We know in the state of California it's against the law, and really just for that reason. A distracted driver is a very dangerous driver, and they get into accidents. Drug and alcohol use. And many times what is happening in the adolescent mind is their judgment, remember their abstract thinking is not quite as high as an adult, and their judgment is not always the best. They will tend to have a feeling of immortality, which of course as nurses we know is not true, and most of us as adults we know is very much not true. So they are more willing to involve themselves in higher risk kinds of behaviors because it doesn't quite seem real to them that some of these terrible things can happen, like car accidents. I don't want to take the time during this lecture, but I'm sure you, and I know me, I certainly could list, just in my personal life, not even bringing up my professional life, a good number of teens that I know have died due to car accidents or some other kind of risky behavior, especially related to drug and alcohol use. We all know drug and alcohol use, of course, also affects, gives us an impaired driver. So as much as we can, we do really want to educate our pediatric patients about these kinds of things. Motor vehicle accidents, sports and sports injuries. There can be, such a heavy involvement in sports that we have head injuries, we have heat stroke sometimes that comes about, especially our football player kids that are practicing in the middle of the summer. Violence, their risk of death and injury from violence is higher too, just because that age group sometimes can feel less threatened, and sometimes they can be less wise about staying out of situations that might involve some violence. Teens and medical care is a really important thing for us to talk about. And one thing, if we were going to the pediatric clinic this summer, which unfortunately because of COVID-19 we can't, but when I assign you to pediatric unit, one of the things you would realize is that the teens there have a right to privacy, and actually the parents, they have a legal right to privacy in the state of California. It's not just recommended, they have a legal right to it. And so physicians like to have some time where they can examine adolescent without the parent present. They can open up a discussion with the adolescent in terms of drug use, sexual activity, some of the things that we know will really can really cause harm to that adolescent. And so the state has really tried to protect all pediatric patients by giving them a chance to talk to medical personnel without fear of what their parents might think, say, or do. Now, we all would hope teens can talk to their parents, but in terms of medical care, you do need to understand that child has a right to privacy during an exam and a right to be able to talk about some things without a parent present. And some children do really need this. Some do. Sexual and reproductive health is one of the things that becomes important when we're taking care of teens. And again, they have a right not just to be able to speak with their physician and nurses about sexual and reproductive matters without a parent present, but they also actually have a right to receive birth control without a parent's knowledge. Depression and suicide can be big risks for teenagers. Whenever we talk about depression, we need to understand that suicide is also a risk that goes along with it. And adolescence is a time of more risk. So, something you should be sure that you are assessing your adolescent patients for, and picking up if they do happen to say something to you. I mean, open up the conversation to something more. Okay, we have just a few more slides with this lecture. The hospitalized child, what kinds of things are most important for you to know? One is that we really encourage families to be present. So remember, we talked about the fear a child might have. That is hospitalized. They're in a strange environment. They can have anxiety about being separated from their family. We really encourage families to be present, and we'll even put cots in the hospital room for the child, so a parent can stay overnight with the child. Siblings are allowed in, and we of course have to be careful about any kind of communicable diseases, but we we don't completely isolate that child from their family anymore, and we haven't for 20 to 30 years. We encourage parents to keep up some of the same routines that the child's been following at home if possible. So for instance, if the child always had a bedtime story read to them by their father, we would encourage the father to do the same thing in the hospital. Medication administration, I've already talked to you about. Very important. We're going to be sure we are giving accurate doses. We need to understand that the child is even more susceptible to harm if the wrong dose is given, and there's just not as much room for error there. You may have wondered a little bit about intake and output with our children that are still wearing diapers. And so what we do is we actually weigh the diaper dry, and we'll know that the diaper weighs that. We don't weigh every diaper we put on the child dry. We know that the diapers that we're putting on the child have a certain weight. And then once the child wets, the nurse takes that diaper off, weighs that diaper, and the difference in weight is what we count as the output. Okay. IV, I know some of you will be certified as IV. You're able to give IVs in the state of California as LVNs. You want to understand very, very clearly that it is much easier to fluid overload a child with IV fluid than it is an adult. Fluid overload, of course, is always a problem. But if you are LVN and maintaining an IV, you want to be sure it's the correct weight. You want to be able to recognize signs and symptoms of congestive heart failure. You want to have some kind of volume control on the IV, and you want to also have it on a pump. And generally speaking, we don't make large amounts of IV fluid even available to children. So you may be hanging something that is a 100 cc bag and running it at 15 milliliters an hour, something like that, okay, or 20. Also, we keep high top cribs for our toddlers. Remember, we talk so much about safety and the fact that toddlers can climb out of bed and they're so much more mobile. Medication administration, we've talked about some already, so you're going to double check any kind of weight dose medication that is ordered for a pediatric patient. You're going to double check all infant medications. Now, double check, we mean one licensed nurse is going to check with another licensed nurse. All right. We crush medications as needed. We will put them in some liquid sometime as needed. Our children that are less than 2 years old getting an IM injection, we're going to use the vastus lateralis. Remember, we talked about that earlier, but it's that middle third on the outside of the thigh that we're going to give an injection. We would never give more than 1 milliliter IM to a child that's less than 5 years old. And those are the main things, okay? We also, of course, aspiration precautions, as we would for anybody. Hold a baby's head up. If you're giving them something oral, don't have them laying flat on their back. Child abuse is also an issue, and remember, I did mention that we are mandated reporters. We're not mandated to decide is that child being abused or not, but we are mandated to report that we have reason to suspect a child might be being abused. So it can be different types of abuse that we can be concerned with. So physical abuse, emotional abuse or neglect, real physical neglect. Some children, their needs for nutrition, for instance, needs for supervision aren't met. You could call that a physical neglect. Some children are sexually abused, and any kind of sexual activity, of course, with someone 18 years, some states it's 16, but any kind of sexual abuse is considered illegal and should be reported. The child is not looked at as someone that can give consent. And as I told you before, nurses are mandated reporters. Well, who do we report to? We're going to report to child protective agencies. And that is the end. So these are just the main things. I hope you've enjoyed it. I hope it's kind of sparked your interest a little bit in caring for pediatric patients. Personally, I've really enjoyed the times that I have cared for pediatric patients, either in an intensive care or just on a pediatric unit. It's not everything. It's not everything that's in your textbooks. And remember that Canvas assignments are there to give you a broader experience as you try and learn more about pediatric nursing.